We are presenting our novel technique for a double-double row arthroscopic rotator cuff repair. These are our disclosures. This is a very active 68-year-old male patient who enjoys skiing and daily exercise. He has occasional shoulder pain that has been worsening. He describes this pain as sharp and achy. He had a left AC joint separation at 25 years old, which is treated non-operatively. He recently had a left subacromial injection, which gave him temporary relief for about a week, but the pain soon returned in a more severe manner. Additionally, he has tried physical therapy and medications, including naproxen, to no avail. On a physical exam, he demonstrated external rotation of 35 degrees with normal movement for internal rotation, flexion, and abduction. He had full muscular strength for forward flexion, external rotation, and internal rotation, but slightly decreased abduction strength where he experienced pain. The MRI and CT scans show a near full-thickness bursal-sided supraspinatus tear at the anterior leading edge. The tear spans approximately 10 millimeters in width and is surrounded by moderate tendinosis. The patient was placed in a beach chair position with the head elevated to about 60 degrees. A Tremano arm positioner was used to keep the arm in a neutral position. An initial diagnostic arthroscopy was performed utilizing a standard posterior portal and mid-glenoid portal with a 5 millimeter cannula in the rotator interval. A combination of a basket, shaver, and radiofrequency wand were used to debride the intra-articular portion of the shoulder joint. Due to the instability, significant synovitis, and scarring of the long head of the biceps tendon, a biceps tenotomy was performed to prepare for a mini-open biceps tenodesis after the rotator cuff repair was completed. Attention was then drawn to the supraspinatus, where a tear was noted at the greater tuberosity with 1 millimeter of retraction. A second anterior lateral portal was made up against the acromion, and an 8 millimeter passport cannula was inserted. To prepare the greater tuberosity, a high-speed burr was used to lightly decorticate the tuberosity to induce bleeding bone. The supraspinatus was then mobilized and reduced into a good anatomic position with a cuff grasper. To start the double-double row repair, two 2.6 millimeter knotless fiber-tack anchors were placed about 1 centimeter apart for the medial row. Then, a Scorpion anterior grade suture passing device was used to pass the fiber-tack suture through the supraspinatus. After passing 2 strands in a horizontal fashion to obtain anatomic reduction, the suture was then tied immediately. The anchors must be daisy-chained to one another to create a bridge. Next, the traditional double-row suture bridge technique was performed by taking a strand from each medial anchor and securing them laterally with 2 4.75 millimeter swivel lock anchors. To complete the double-double row, sutures from the medial anchors were daisy-chained to an anterior-based 4.75 millimeter swivel lock anchor in the bicipital groove to create anterior footprint coverage. The repair was then assessed for anatomic reduction and footprint compression, both intra-articularly and from the subacromial space. Proper range of motion was ensured by taking the repair through passive range of motion tests. Finally, all instruments were removed and wounds were copiously irrigated and closed in standard fashion. The arm was put in a padded abduction sling for 4 to 5 weeks. Due to the biceps tenodesis, resisted elbow flexion is restricted for the first 3 weeks postoperatively and limited to 10 pounds for weeks 3 through 6.